Good morning, everybody. Isn't this a great conference? I've been having a great time. I said they have to have it here every year because they can't really do better than this, so I'm working on that. All right, so you guys all know my background, I think. I trained as a pediatrician. I worked in pediatric emergency medicine for many years, had a little need for some sanity, took some time off, and my friend was fighting cancer, asked me about cannabis, and that was my introduction, was to do research for my friend, and I haven't looked back. So let's see. I think this is a fine setup for me. So I'm just going to talk about the minor cannabinoids in clinical practice. You've heard some about this already from Dr. Russo and from other speakers as well. And here is the phytocannabinoid synthesis, showing that CBGA is kind of the mother, the precursor of all the other compounds. And as you can see, we have numerous raw compounds, heated and as well as aged. Remember, too, there's CBGVA, which is a parent to the varin line. And today we're going to talk about the ones that I'm circling here. I do agree with Dedi that we can no longer call, and which he mentioned yesterday, we can no longer call CBG a minor cannabinoid. I think it has moved up into the big leagues, and so it's becoming very popular. It clearly has incredible benefits, and that is what I'm going to be showing you now. First, we'll talk about CBG. So here's all the targets. So again, multi-targets. Very hard to predict somebody's underlying chemistry and how they're going to respond to CBG. But the one I want to point out, the star should be a little further down, that alpha-2 adrenergic, because it is what stands out separately from some of the other cannabinoids. We don't see that with the other cannabinoids. And this particular target can help with numerous disorders, and I do see it help with numerous disorders. And then I also just want to point out the TRP channels. I find that a lot of people don't really know what those are, so here I'm just going to give you a cheat sheet, so take a picture. It's a lovely article, and this is your TRP channel. This is a family of ion channels that was discovered in 1969. They promote sodium and calcium influx into cells. They're involved in many diseases, including neuropathic pain, inflammation, respiratory disorders. They're activated by many different triggers, including heat, cold, mechanical skin changes. So like when your skin stretches, that's your TRP channels. Spicy foods, toxins. If you've ever had really good freshly made olive oil and you get that peppery taste in the back of your throat, that's with your TRP channels. And also, of course, by cannabinoids. Here are some of the ones that we know that cannabinoids target. There are many more TRP channels. And here's your cheat sheet. What are they involved in? So nervous system, gut, immune. Does that sound like the endocannabinoid system? Yes, it does. And the skin. Pain, inflammation, itch, and cancer. There are many other things, but this is just giving you kind of a boiled down way to think about TRP channels when you read about it in the research or somebody's talking about it as a target for cannabinoids. So CBG is anti-cancer through the TRPM8, and you can see here CBG hampers colon cancer progression, selectively inhibits the growth of colorectal tumors, and again, this is a preclinical model, this is not a human model. Also, we have now Cannabigerol showing potential for glioblastoma multiforme, which has been talked about quite a bit at this conference. Remember that this is a condition that is quite deadly. 200,000 people die each year, 15,000 in Europe, 9,000 in the US, according to gliocore.com. And CBG was found to be comparable to THC in killing glioblastoma cells, inhibiting the invasion of these cancer cells, and also, very importantly, destroying the therapy-resistant stem cells. And those are those stem cells you may go through treatment, be told that you have no evidence of disease, but you still have some of these cells lurking. Jeff Hergenrather, a fellow cannabis physician in California, who's been doing this longer than I have, had a patient who stayed on cannabis for 9 years after his glioblastoma was surgically removed, and he stopped cannabis and his cancer came back. I had a patient in my practice 3.5 years with glioblastoma, was doing great, decided to travel the world with his kids and left his cannabis at home, and he relapsed within 5 or 6 weeks, I think. And unfortunately, when it came back with a vengeance. So it's my opinion that if you get to NED with or without cannabis, you probably should continue to use cannabis. What else are you going to take? You can't take chemotherapy and get radiated, right? So what else can you do? You can take care of yourself, but include cannabinoids as part of your anti-cancer protocol. And I tell this to every patient, and I'll just share one last story. I had a 3-year-old come to me who had a terrible version or chromosomal type of leukemia. And at 3, it's so difficult to treat these kids because they're aware enough to know what you're doing, but they're not old enough to understand, so it is torture for them. And she ended up getting a bone marrow transplant. She relapsed 3 months later, came to see me. She was in remission with cannabis and a plant-based diet alone in 8 weeks. That's pretty quick. They stayed on cannabis for 8 months. I don't know what happened in the family, but apparently there was some disruption in the family unit. They couldn't afford the cannabis. They didn't call me, and she relapsed about 3 months later and then got another bone marrow transplant and died from fungal pneumonia. So, and by the way, her bone marrow, when they checked her bone marrow, it had 100% grafted. So she was actually doing really well. And I really do think that going off cannabis was probably not a great thing. What else about CBG? So it reduces neuroinflammation. So this is a preclinical study looking at CBG alone and in combination with CBD. CBG alone wasn't really found to be effective. CBD was effective at a very high dose, but when combined, as you've heard over and over during this conference, it was the most effective, downregulating pro-inflammatory compounds and increasing anti-inflammatory compounds. And then they also showed in this study some PPAR-mediated anti-inflammatory, antioxidant, and anti-apoptotic effects. And remember, the PPARs are the receptors that sit on the nucleus inside the cell, also interacting with cannabinoids. Analgesic, we know that from this particular study that it reduced chemo-induced mechanical hypersensitivity, which is kind of a model of neuropathic pain. A combo of CBD and CBG, here it is again, was more effective than CBG alone. Now, I found 3 articles on appetite stimulation. I do have patients that tell me that CBG gives them the munchies, and I don't think that happens for everybody. But reading through these articles, there's some indication that CBG may help with chemotherapy-associated weight loss and loss of appetite. And who might this help? Well, someone who might be reluctant to take THC, they're getting drug tested at work, or they don't like the effects of THC, or they don't have access to THC. So this might be helpful for patients. I think I'm still not sure exactly if this is a true effect. I have not treated anybody who has this particular indication. Now, also metabolic homeostasis. So this is a really interesting article. I had to read it about 5 times to understand it. But what's really interesting about it is that it showed that CBG, acting through PPAR, improved insulin sensitivity. And THCV gets a lot of credit for that, but CBG appears to do something very similar. Also improves adipogenesis. So what is that? That's creating fat cells. Now, you might think, well, we don't want to do that. But remember that there is a physiologic reason that you have fat. You just don't want to have too much fat, and part of that is to help prevent lipotoxicity of organs. You don't want your lipids to get into your heart and your liver and other organs. And so CBG appears to help with this metabolic homeostasis. It's also anti-psoriatic, having skin effects, and I think there was a CannMed a couple years ago that someone did this, presented this. It inhibited pro-inflammatory cytokine release due to certain triggers, including UV light, chemical irritation, and bacteria that causes acne, and in some cases was more potent than CBD for this indication. Now, Ethan touched on this yesterday, so I'm not going to spend too much time on it, but this was the first survey of patients using CBG, and these are the most common conditions that he discussed, and needless to say, it was highly rated by participants and reported greater efficacy than pharmaceuticals. with some mild side effects, which appeared to be THC related, as some patients had preparations that had THC in it. Now we're going to move on to CBDA. Ben, will you give me a heads up at 5 minutes, by the way? Thanks, okay. So here's your CBDA targets. I actually had to change this yesterday. I had to recreate because I've been looking at the literature. There's no CB1, CB2 activity, and lo and behold, what do you find when you look to make sure you're not leaving something out, the latest literature, because it's kind of coming down pretty quick. In that same study that I just talked about, they report that CBDA does act through CB2. At least what happened was when they used a CB2 agonist, it blocked this effect. So there may be something else there, but it is a signal that maybe there is some activity at CB2. And again, what is this? This is converting bone marrow mesenchymal stem cells to fat cells, so increased proliferation. And so very interesting. And then I was really happy to find this because Dr. Meshulam did this in February. This was published February 23. Cannabinoid receptor 2 blockade prevents antidepressant-like effects using the more stabilized version of cannabidiol in female rats. And so if you want to take a look at that, another study that showed that blockade blocks the effect. And is CBDA working through that CB2 mechanism, whether directly or indirectly? We don't know yet. In terms of anticonvulsant effects, there's 2 studies that came out, again, preclinical, and you can see here that they were looking at pharmacokinetics of the phytocannabinoid acids and also the anticonvulsant effect of CBDA in a mouse model of Dravet. If you're not familiar with Dravet, it's a genetic disorder that causes very severe cognitive problems and also horrific seizures in children, and it appears about 2 years of life. So these children kind of look healthy for the first 2 years of life, and then they start having terrible seizures, usually in response to heat or a fever, and then it just goes downhill from there. What did CBDA do? And you can see the 2 bars to the right at CBDA significantly increased the temperature threshold. I actually had a Dravet patient come into my office when the air conditioning was out, and the parents would not bring her into my office. We had to do the evaluation out in the hallway because they were terrified with the heat in the office that she would have seizures. So this is a real concern. CBDA has some signaling here for anticonvulsant activity, and here's another one exhibiting entourage-like improvement. So in this study in rats, what they did was they created a compound that they called Glioblastoma, 74% CBDA, but other cannabinoids included. And they also used this model of adding a magnesium to help these compounds transport through lipid barriers, lipid cell barriers. Then they had a magnesium CBDA. It's almost like a pure CBDA, and you can see it does not have the CBD and the THCA. It has slightly less THC, also has similar amount of magnesium. And then they compared it to a CBD isolate, 99.99%. And all the compounds were anticonvulsant, but the Glioblastoma exhibited potency at a level statistically significant, similar to CBD. And also the minimal effective dose of the Glioblastoma was significantly lower despite having a less potency of CBDA when compared to that magnesium CBDA that didn't have the other compounds. And so again, this kind of points to synergy or entourage. So remember that that's part of it as well. And so that was an interesting study. I've used CBDA in some of my pediatric patients with severe intractable epilepsy who did not do well with either CBD or THCA or THC. And you have to remember, in California, things kind of came down the line. It wasn't all available at once, so I got to introduce things kind of in a chronologic way and kind of see how they worked. CBDA does show some activity for some patients. A lot of the families say, my child just seemed less agitated. And is that treating the neuroinflammation, possibly? Is it overall inflammation? Is it gut-brain? It's hard to know. And so a nice article, if you want to look, Formato in 2020 gave this nice slide of just kind of the summaries. And so you can see this anti-inflammatory effect at not only the receptor level, but also transcriptional level and the enzymatic level, lowering COX-2, antiemetic in the way that it interacts with the 5-HT1A. And I have used CBDA. I had a breast cancer patient many years ago who was on high doses of THC and CBD. She was quite tolerant to the THC at that point, and she started a new chemo, which made her have terrible nausea and vomiting, and low-dose CBDA took care of that. So we just added it in. I don't know that it's an N of 1. I don't know if that will work for everybody else, but it's something to think about in patients who either don't want to take THC as an antiemetic or who need an add-on. I've already talked about anticonvulsant and then also anti-cancerogenic, and so there's some evidence in breast cancer, a couple breast cancer studies that show decreased cell proliferation and decreased cell migration. So just a nice study of the summary of the medicinal properties. Here's a patient report. So this is at the other end of the spectrum. I still have adult patients that I follow for many, many years. This is a 91-year-old male who has been a patient for 6 years. I'm smiling because every time he sees me, he always asks me, how's Dr. Russo? He's a huge fan, so I just wanted to let you know, Ethan. He goes, tell him I say hi. So age-related ailments, avid reader of the cannabis research, which he only discovered as he was older. He had arthritis and insomnia, which California, I can approve him, but he was really looking for wellness. That's what he said to me. I want wellness. I want to be well in my old age. And so he was taking a low-dose preparation of 4-to-1 CBD to THC. That's what he found to work well for him. It helped his arthritis, and it helped his sleep. Then I got a call from him that he had developed gout. And he was given opioids by his primary care. And he said, not only do they not work, but I haven't pooped in about 2 weeks, and I'm miserable. And he actually said to me, I don't want to live if this is how I have to live. You have to help me. The 4-to-1 helped, but it really did not take care of his pain. And the other thing is it was restricting his ability to be mobile. He was sitting at home with his leg elevated and putting ice on, and he's a guy who he lives near the water, he likes to go out for a walk, and very active older person. So he happened to have some CBDA capsules that I had recommended the last time when he came to see me for his arthritis. It was a fairly new product. And so these capsules come as 25 milligrams. If you've tasted some of the CBDA preparations out there, anybody have a bad experience? They're very, very, yeah, so Kevin, they're really difficult. They just terrible taste, and people don't like them. So I didn't want to turn them off to it. So I just started him on 2 capsules twice a day. And by the way, I didn't feel that I had time to start lower and go up. I wanted to kind of hit him hard and get the inflammation down. I gave him dosing instructions over a period of 2 weeks. He did it in 6 days, and he had complete resolution of the pain. After 2 weeks, he said, it's a little pricey. I'm going to try to lower my dose, but the pain returned. And he figured out if he took 150 milligrams once a day, that his pain was fine. The last time I talked to him was to renew his letter, and he said, everything's fine. I don't really have time to talk to you. We're going to have to reschedule because I'm having lunch with my friend, and I think he forgot the appointment. And so he remains pain-free. And so he continues to take his low dose 4-to-1, and he's still taking his CBDA. Now let's talk about THCA. So again, multi-targets, and the reason I made these charts was because I was starting to get confused on which cannabinoid targets which receptors. It's hard to remember them all, and so I made these targets. And we know that THCA does have some activity at CB1 and CB2, and again, you have to remember, though, that THCA is very hard to isolate completely. There's always going to be a tiny little bit of THC, so it's always hard to know when somebody has a response to THCA. Is it because of that little bit of low-dose THC that might be in the product? So here's some 3 studies that I wanted just to show you. So THCA reducing adiposity and helping with metabolic syndrome. Also, THCA is a potent PPAR agonist showing neuroprotective activity. And then this last one from Hananit, who's here in the room. So thank you for your research, showing anti-inflammatory activity through the GPR55 receptor. It's different labs find different affinities, and that's why it's kind of hard to know what's happening at the cannabinoid receptors. We also know that THCA can be a very potent anti-nausea medicine in very low doses. And of course, I've used it for anti-inflammatory effects in my patients. Oh, I'm sorry, that bottom one should be not there, but you can see the top one is an article that Dustin and I published along with Dr. Russell Sanito, who's a neurologist at Seattle Children's Hospital. And if you'd like to read about THCA and pediatric epilepsy, there's a really nice section in there that Dustin wrote that's really beautiful and explains THCA quite well. And then here's another article that came out showing some possible anticonvulsant effects. This was really mixed, and what they found was in a focal seizure model that THCA was anticonvulsant, but only when THC was present with it, but it wasn't effective, and it was also found to be proconvulsant in some other seizure models in the purified forms. I have used THCA in my patients, and I'm going to share with you one of my stories. So this is an actual chief complaint list of a 17-year-old that came to see me. The mom has to type it out because she has no room to put it on the paperwork that we give her. So he started off was born in the year 2000, and he was diagnosed with autism, followed by seizure disorder, hypoglycemia, polydipsia, sodium imbalance, finally got genetic workup, mitochondrial disorder, with all kinds of variants in the genes that you can see listed there, and I don't know that anybody knows. I think he's a unicorn. Cyclical vomiting syndrome, hearing loss, OCD, pandas, and the pandas oftentimes is fine until the spring, and then in the spring he gets pandas. I have other kids that do that too, and I don't know if it's pollen or something else that's triggering them. Intestinal malabsorption, he's also got some heart stuff going on, and he's just a really challenging patient. And then after showing me this, we get this. Look at all of what the mom calls allergies. So gluten, casein, soy, antibiotics, antivirals, and if you look, you can see what happens. Rash, tongue swelling, hives, and so on. If you go down a little bit, you'll see omega-3, 6, 9, EPA, GLA, all the fatty acids, severe aggression, mania, self-injurious, regardless of dosage. So I was a little nervous to give him cannabis because of the lipophilic nature, but the mother was willing to try because nothing else was working, and she really did not want to continue to give him any more pharmaceuticals. And even you can see he reacts to garlic and onions and coffee. I mean, he's a real unicorn. So he was having seizures every 20 to 30 days on average. There were clear-cut triggers. If they wake him up in the morning, instead of allowing him to wake up on his own, he'll have a terrible seizure. I know people think it's crazy. There's two articles, one that says yay and one that says nay, about the full moon. The mother says he has seizures around the full moon, and I will tell you I have the moon app on my phone because my phone lights up around the full moon with seizure kids, so there's something there. They did try CBD before seeing me. She gave him 1 drop, and she said he was horrific the rest of the day. He was completely manic and self-injurious, so she came to me asking for advice. I was so nervous. I was really reluctant to put him on cannabis, but I wanted to try to help him, so I started him. And by the way, at the time, I didn't have everything that we have now. What I had was CBD, THC, and THCA. So we decided to go with THCA. He started with 1 drop, and after just 1 drop, I think it was per day, he went 57 days, which was longer than he had gone in quite some time. And so we continued to titrate up, literally adding 1 drop at a time, and the longest he went was 229 days, which was really exciting. Of course, there's still a lot of triggers. Mom keeps track. We get 150 days, and then he'll have a seizure. Sometimes it's 7 days if there's something else going on. Surprisingly, when he got sick with COVID, he didn't have too many seizures. He's on a pretty high dose, as you can see. We've just been titrating up over years, 60 to 80 milligrams per day. She does regular TID dosing plus PRN dosing. He has no side effects. And he's on 2 different chemovars from 2 different companies, as that seems to be what helps him. And this is kind of the art of medicine and the evolution of following a patient over time. One thing I'll share is that when CBDV came out, which I'm going to talk about next, and I'm going to pack it into a few minutes here, we tried 1 drop, and he had a seizure, so we just decided not to try it. And she's very happy with what we have now, and this is why it's so important for new cannabinoids to come out for us to be able to help these kids who are unicorns. So here's your targets of CBDV. Again, questionable activity at CB2, but definitely GPR 55, and I'm going to talk about this GABA rundown, also a little bit of activity at the TRP channels. There's a patent out from 2018 that shows that CBDV is effective at reducing pain better than CBD for both thermal hyperalgesia and mechanical allodynia in a mouse model of neuropathic pain. I haven't tried it yet in I have tried it. I haven't gotten a response yet or feedback yet. And then the TRP V1 also thought to be a target for the anticonvulsant effects. And if you look here, you can see that the epileptic brain on the left side is showing this increase in TRP channel phosphorylation and sensitization, and then the epileptic brain on CBDV has lowering of that, which it tips that excitatory message to the inhibitory message. So that's the idea, one of the ideas with CBDV. And then also I'm just going to mention this one other study about CBDV lowers intestinal inflammation in mice and in pediatric ulcerative colitis biopsy tissue where V1 is upregulated. And so there's the article for that if you want to read about that. And I was kind of thinking as I was putting the slides together, CBDV and THCA might be a nice combination for inflammatory bowel disease in a non-intoxicating way. And then this just comes from that same article showing the pathway that CBDV lowers that inflammation. All right, and so there's this nice article, I think this came out of Italy a number of years ago, and they talk about GABA receptors and that CBDV recovers this idea of GABA A receptor rundown. So I'm not a neurologist. I didn't know what that meant. I did a deep dive, and my neurologist friend here is shaking his head. So what I found is that in drug-resistant epilepsy, the constant seizures basically wipe out GABA, and the pathways are run down, exactly what it sounds like. And CBDV in animal models recover this rundown. That's pretty big claim there, and I think that I am seeing that in my patients. Now, there's other studies, multiple animal studies reporting anticonvulsant effects of CBDV. Getting to my end, Ben, so don't worry. Case report of a young man with Rasmussen encephalitis in Italy who, and if you're not familiar with that, it's a terrible disease, and you have terrible seizures, and it's just neurodegenerative. And he was taking a homemade CBDV-rich preparation with significant improvements in his quality of life, never thought to be able to graduate high school. He graduated high school, he had improved verbal skills, and they plotted out, and they even measured his blood levels, and when his blood levels were high with CBDV, he had significant improvement. Now, there was a clinical trial at a GW pharmaceutical with CBDV in adults with poorly controlled focal seizures, but it failed to reach the primary endpoint. A study that came out in 2019 showed in mouse models of Rett syndrome, so again, this is like a unicorn syndrome, usually affecting females. Again, they're usually healthy for the first couple years of life and then become quite ill. It's a genetic disorder, and they have all kinds of social impairments and behavior issues. They have odd hand-wringing kind of motions. They have severe drug-resistant epilepsy. And so in a mouse model, CBDV rescued social impairments, short-term memory deficits, repetitive behaviors, and hyperlocomotion, and then also restored endocannabinoid alterations from prenatal exposure to valproic acid, which is the model for autism when we look at a mouse model of autism. So quite interesting. Then we have this study that was published last year, a phase 1 pediatric clinical trial from Australia in 5 kids with Rett. These were all drug-resistant patients, one having as many as 370 seizures a month. And they started with 2.5 milligram per kilo per day and titrated up in the same increment, not going further than 10 milligram per kilo because they were told that it would cause sedation. And they saw this median reduction of seizures, 79%, that corresponded to an overall decrease, 32 seizures to 7 seizures a month. And I will tell you, for families that live with seizures, all the parents have, I don't call it PTSD, it's ongoing traumatic stress disorder because they never know where or when. They might have to call 911 or if their child's going to die. Just going from 32 to 7 a month completely changes the quality of life for everybody involved. And remember, too, less seizures mean the brain can move forward. Well tolerated with no serious adverse effects. And this is my last slide. So this is one of my very long-term patients. She was one of my first pediatric drug-resistant epilepsy. I've become very friendly with the mom. I give her respite care by going with her to museums on the weekends, because my husband won't go with me. When I first met her, she was 19. She's almost 29 now, and she's had seizures since age 2 months. She is nonverbal. She requires full-time care. She's in a wheelchair, in a diaper. She has to be fed. This is what seizures do in childhood. Saying cannabis, we don't know enough about it, is cruel. We know enough to know that it's safe, and you have to try it. Brings me to tears, sorry. Anyway, highly refractory daily seizures. Her brothers became really good at kind of knowing the seizure was coming. And the mom even told me when I first met them, she said they're the ones that will grab her and bring her to her bed that's all kind of padded so she can't get hurt. Imagine growing up that way, her 2 younger brothers. 22 different anti-epileptics. Knowing that after 2, the chances of 3, 4, 5, 6, 18, 19, 20 working is really less than 1 to 4%. So she started CBD back in 2013 when it was really hard to get. And she had greater than 50% reduction of seizures kind of right out of the gate. We titrated up to 6 milligram per kilo, but she's sensitive to it. And if we went any higher, she started having some more seizures. We tried other cannabinoids with minimal benefits. Over time, she improved eye contact, started smiling, just an overall wellness that the mother said she just is well. And those days, seizure-free days, started to accumulate. And as you can see, and I talked about this in the medical practicum on Monday, the longer you stay on cannabinoids, the better response you get. It shows up to 2 years, you can have an increase. So I always prepare patients. What you see now doesn't mean it's not going to get better later on. You have to give it a chance. It's a botanical medicine. It nudges. It doesn't hit hard. She was able to wean 1 medication, no side effects with CBD, but she was still having some seizures. So I just started her on CBDV, and she's been seizure-free, the combination. And so she's on 4 milligram per kilo per day of CBDV and 6 milligram per kilo per day of CBD, which is still fairly affordable for the parents, and doing really well. And as you can see, she looks pretty content right there. And thank you very much. I don't know if I have time for questions. I think Ben left the room, so go ahead, take questions. Oh, there he is. One question.
Okay.
I thought you left.
Well, I feel honored. One quick question. First of all, I'm very humbled during this whole experiencing all this, sharing experiences with everyone here, so it's very enlightening and very inspiring. I had a question with the CDMA, CBDA, a lot of letters.
CBDA?
Yes, regarding why it's more efficacious than others for this. Is it have to do more with the blood-brain barrier? Do you think it's...
You mean CBDA or CBDV?
CBDA, my apologies.
CBDA.
Yes.
So I would say that if you're asking about seizures,
Yes.
I think CBDV, in my experience now, and again, this is all just my anecdotal experience, is significantly better than CBDA for seizures. But again, I didn't have CBDV, so I got to try out CBDA. And I even have another child right now. The parents were spending a fortune on the CBDA, and we weren't sure it was making a difference, so we weaned down on that and introduced CBDV, and seeing a much better decrease in seizures. That's just my experience. And it may be because it's not penetrating the blood-brain barrier. There's some research showing that in oil, the ratio in plasma to brain is not very good, but that in a tween emulsion, like something that's an emulsifying agent, that actually that can help get it through the blood-brain barrier. There is one product on the market that does it, but it's very expensive, so I think I only have one patient on it.
Are there current clinical research studies looking at the actual numbers in the spinal fluid? Is there a way of actually obtaining spinal fluid?
Not in humans. No, I don't think so.
That'd be interesting.
No, it's hard to get a parent to agree to give spinal fluid. It's hard to get them to do it when you think they have meningitis. So.
Well, in the emergency room, we do LPs all the time. I'm wondering.
Right, and there are studies that show that when patients come in with first-time temporal lobe epilepsy, if you check spinal fluid, there's low levels of anandamide. So certainly, if somebody's doing that kind of study might be able to check and see if it's there. It's all animal models like at this point. Thank you. Thank you, everybody.